Hello and welcome to the Recovery Channel. I'm Dr. Richard Whitney, a Medical Director of Addiction Services at Shepherd Hill Treatment Program in Newark, Ohio. We've been talking about treatment for the disease of addiction, how it occurs, how people get into treatment, how long they have to stay in treatment. But this is a very important subject in my area of being a physician involved in treatment, because finally, over the last 10 years or so, we have developed medications which can dramatically improve patients' response to treatment for this terrible disease of opiate addiction. Why is this still a controversial topic? Well, a lot of people say, well, the medicine really doesn't work, or the medicine is just a crutch, and you shouldn't have to use medication to stop using drugs. You should use willpower, etc., etc. Why use one drug substituting for another? Why is it we say this in 2014? We don't say, well, just pull up your bootstraps and fix your depression. I don't care if you're suicidal. We shouldn't use a pill that's going to affect the way you... We don't say that. We accept depression as a brain-based illness, and bipolar disorder and schizophrenia as brain-based illnesses, and wouldn't consider advising people not to take medication to bring about a better result. How can we possibly talk about the incompatibility with the abundance of scientific medical literature, not just drug company funded, but tax funded from the National Institute of Drug Abuse, that dramatically shows that medication now is becoming rapidly the standard of care for treatment of the disease of addiction? All of this abundance of medical literature and scientific studies clearly shows the long-term effect of medication for use in the treatment of addiction. And shouldn't we want our patients, our loved one, our families, our fathers, our sons, our children, other members of society to have the benefit of medications which can increase their abstinence from drugs, complete treatment, decrease medical problems, physical problems, overdose deaths, criminal behavior, incarceration, quality of life improvement? Why shouldn't we use good, safe medications if they can bring about these improvements? Okay, well, let's talk about two general classes of medicines that we do have now in the 21st century to help people with the disease of addiction, specifically opiate addiction. We have two different types of drugs. One's called an agonist group, the other is an antagonist group. If we look at brain chemical receptors that are naturally occurring within the brain, then an agonist is something like morphine, opium, heroin, codeine, Dilaudid, Percocet. That molecule goes in, hits the opiate receptor in the brain, turns it on, unlocks the door, and produces the effect of opiates. However, therapeutic medications do so in a different manner. It doesn't get people high. It doesn't make them crave. It turns off cravings only by mildly stimulating and then holding on to that opiate receptor, so we won't want to use heroin, or if we do, we won't get the beneficial effect. That's called an agonist, or essentially the accelerator pedal. The other medicine that we have is an antagonist, okay? And like in literature, the antagonist is against the protagonist. The antagonist actually blockades the brain receptors of opiates, okay, and prevents opiates from getting in and turning on that opiate receptor. Nobody in our society really has much problem with this type of medicine, especially judges, family members. It has good outcomes and so forth. But just like antidepressants or medicine for bipolar disorder or insulin, one drug does not fit all. We have to pick the right medicine for the right individual at their stage of addiction. Now, today in the 21st century, we have one main molecule, one generic medication that's an antagonist that blockades the effect of opiates. This is the drug naltrexone. This has been around for many decades. It comes in oral form by many generic companies. The original brand name was called Revia. And now we have a wonderful new formulation of this medicine. It's a once-a-month injection. It's injected into a large muscle in the body like the buttocks, and it's slowly released over the course of a month. So people don't have to take the pill every day, remember to take the pill every day, or want to take the pill every day. It's present for the entire month. We have two main medications down here below that are agonists that turn on the opiate receptors. One is methadone. A lot of us have heard about that. Another one is buprenorphine, the most common brand name of which, the first brand name, is called Suboxone. We're going to talk about all these medications. First, we're going to talk about the antagonist naltrexone. Naltrexone, again, is a chemically altered form of the molecule oxymorphone, which is brand name Dilaudid, but it's been altered so it doesn't produce any high, euphoria, pain relief, physical addiction whatsoever. It only goes into the opiate receptor in the brain, covers it up, and holds onto it and blocks it. I'm going to have a little picture here, just a little bit of what that looks like. Now, this is reversible. The naltrexone lasts for about a day and then has to be either swallowed again or more of the chemical has to be released from the muscle. This will make more sense when we have some pictures here. Comes as 50 milligram tablets, lasts for about a day. 50 milligrams completely blocks opiate receptors. Up to 25 milligrams is a big dose of heroin. And 100 milligrams, 2 tablets, will block opiates for 2 days. But it's easier to remember to take a pill every day rather than every other day. This is what the brand name Revia looks like. There's a lot of generic formulations right now, much less cost. These usually cost somewhere between $2 and $4 per tablet. Insurance pays for it very well. Now we have this newer medication. Excuse me, the entire world supply is made in a factory near Dayton, Ohio. It's only one factory. It's in Ohio. And this is called naltrexone for extended release. Okay, we're going to talk about that. What does that mean? How does one shot last for a whole month? Well, in the brain here, let's talk about how naltrexone works. If we look at this green thing right here that looks like kind of like a green grape, this is a molecule of heroin or morphine, an agonist, and it fits right into this cradle of the opiate receptor in the brain. This is the guts on the inside of the cell. This is what's called the cell membrane, okay, that keeps the cell intact. And this opiate receptor is up there looking for opiate molecules that are normally released by the brain. But if we inject heroin, swallow Percocet or whatever, then what happens is we turn on this receptor and we get a sudden burst of electrical energy and we feel euphoric. People say it's like an orgasm. Oh my gosh, I feel great. And when that wears off, I want to do it again and again and again and again. Well, over time, people with the disease of addiction build up what's called tolerance. So you don't use just one grape. You have to have tons of grapes real frequently to hit this opiate receptor. And then when you do, instead of getting that burst of electricity, you get a tiny little burst. So I'm back, I want that big burst of feeling good and euphoric effects and pain relief and, oh, just feeling great. So I take more and more and more of the chemical, getting less and less and less effect. And this can occur in weeks, months, and sometimes years. This is called tolerance. Now, if we insert these little strawberry-looking things here, this is a molecule of naltrexone, whether it's taken by pill or by injection. And what happens is it goes in and it blocks that opiate receptor and blockades any opiates from getting in and turning on that opiate receptor. So essentially, we got a stop sign there saying, you're not going to get past me, not for the next day. You can swallow Percocet, you can take a Vicodin, you can take an Oxycontin, you're not getting into my receptor. The receptor is not producing any euphoric effects at all. It's simply blockaded by this naltrexone. How does Vivitrol work, the once-a-month injection? Well, we have this little blue area here that you can think of as being bread or starch. These are starch balls. They're called polysaccharide spherules, but they're microscopic little starch balls. And impregnated all through this little blue starch ball are little red strawberry molecules of naltrexone. And over time, as we know, our body will absorb starch. And as the starch is absorbed and the ball starts to shrink, these molecules of naltrexone are released into the bloodstream. So again, these are extruded as the starch is absorbed, and you can see here as it gets smaller and smaller, these molecules are released. So we can take a 50 milligram naltrexone once a day or 1,500 milligrams a month, or we can take one 380 milligram injection, less than a third of the amount by mouth, and get the same desirable effects, and we don't have to worry about whether our loved one or our patient has taken the medication because we know it's slow released over the course of a month. Now, who really benefits from this medication, naltrexone? Well, it could be for some reason patients and loved ones who are not interested in taking an opiate, methadone or Suboxone, we'll talk about that later, or they're unable to take it for some reason. They're allergic to it or they have adverse effects to it. People who are really in solid recovery, who really have a good recovery group, are people who are not allowed by law to practice their profession, such as pilots and doctors, who are not allowed to practice on methadone and buprenorphine. Or people who did not work and did not stay sober on using opiate agonists, so they want to try a different medication to help them stay clean and sober. Who are other good candidates for naltrexone? People who just can't stay off the needle, can't stop using drugs when they're on opiate agonists, people who dropped out of treatment, people who can get clean for a few days but who go right back to using again, and people for whom a relapse would be disastrous, such as people with severe medical problems, people on parole that are going back to prison, or pilots or physicians that are going to lose their livelihood if they use chemicals. People who are remaining abstinent, but for some reason they're at really high risk. They've got to go back to work in a pharmacy. They've got to go back to their own neighborhood, okay, where there are friends that are still using drugs. Or people that have severe psychiatric disorders and can't really think and use good coping skills. And perhaps people with a less severe addiction, like younger people with a shorter history of addiction and a lower level of use, might do really well with this naltrexone antagonist therapy. Other people who have a history of a lot of overdoses and absolutely have to have something to save their life, a blockade against their next big shot of heroin, people who don't have a home, people living on the street, who can't think clearly, and people also with chronic pain disorders, chronic skeletal pain, abdominal pain, Crohn's disease, ulcerative colitis, chronic pancreatitis, that might periodically need to have morphine or another medicine to relieve legitimate pain. Probably are not good candidates for naltrexone, and people with advanced liver disease, because the oral form of naltrexone, not the injectable, but the oral form, can be kind of hard on the liver. So that's why we have to select individuals on a case-by-case basis about which medicine is going to work for which clients, rather than saying that one drug is good for everyone. Now, things we have to keep in mind with this medicine, naltrexone, that we don't start it when people are just coming off of drugs or out of detoxification, because we will put them into instant withdrawal, and they'll say, I'm never going to take that again. So we have to wait a week or 10 days for the last use of opiates, especially long-acting drugs like methadone and buprenorphine, before we introduce it into the body safely. It won't kill people, but it'll put them in withdrawal and they'll feel terrible. We need to talk to patients about how it works, how they have to remain absolutely abstinent, and how their tolerance will drop while they're abstinent. What does that mean? It means when people stop using drugs for a period of time, if they go back and relapse, the same amount of drug produces more effect. They have to use, or they can use less drug to get high, which can be dangerous, because a lot of people say, well, I have to use my regular dose of drug, and they overdose and die because they didn't realize that their tolerance had dropped while they're on the detoxification unit. How do we treat pain? I mean, my golly, what if I break my leg or break my ankle or twist my arm on naltrexone? Well, we use non-addictive medications like ibuprofen, injectable non-steroidal anti-inflammatories like Toradol, very effective. Regional nerve blocks, kind of like the same type of medicine that you get when you go to the dentist that numbs your mouth up, can numb nerves up. If I break my arm, I can get a nerve block and get really good pain relief. Sometimes people have to be actually put to sleep, and anesthesiologists have to give them tremendously high amounts if they have appendicitis and need surgery. And we need to have our individuals who take this medicine have an ID bracelet or around their neck or a wallet card saying, I'm on naltrexone, in case they come in unconscious in an ER. But there are safe ways around this. It's really no more dangerous than taking insulin for a diabetic. Now, the next segment after this, we're going to talk about what are called opiate agonists. We're going to talk about methadone, and then we're going to talk about buprenorphine. Medications, very effective, sometimes life-saving with people who are addicted to opiates.